Anyway, it's a privilege to be here. When I was invited to be a keynote speaker at this conference, first of all, obviously it's a wonderful honor to be here, and I had to think about a topic to deliver today. And there's lots of clinically interesting topics to talk about, and lots of interesting debates and current controversies in EMS, and I love talking clinical medicine with my paramedic colleagues. But I think in terms of something that's really timely and incredibly important for everybody, for every EMS provider to be aware of, it's how the national healthcare issues and healthcare reform impacts you in EMS. So I'm going to discuss some of these issues today, and hopefully this will be provocative for you. So you really can't read the newspaper. I don't know if anyone reads the newspaper anymore, or look at your iPad or iPhone, or watch the TV news without hearing about healthcare reform. I think this really sums it up, plus or minus, but lots of controversies, healthcare reform. So it all starts with the Patient Protection and Affordable Care Act, or ACA. So as we know, the President signed this act into law about 2 years ago, and this is absolutely monumental. So this is the largest change to healthcare in America since the creation of Medicare and Medicaid. So this is monumental. And the estimate is this is going to cost about $1 trillion over the next 10 years. So for those of us, everybody here who's involved in healthcare, which includes EMS, if you think this is not going to impact you, you're sorely mistaken. And even if the Supreme Court overrules this law, rest assured there will be substantive changes in healthcare in the next few years. Now, I don't want to get too political on you here, but anyway, okay. So a lot of us might argue that the Healthcare Reform Bill or Affordable Care Act really is a change in who pays, not how we deliver healthcare. I think some of the things I was hoping that would appear in this act, in this law, that really doesn't appear very much is issue of tort reform. And we always hear about the issue of everybody practicing defensive medicine and how practicing defensive medicine drives up the cost of healthcare. But be that as it may, change is coming. So what are the strategies with the Affordable Care Act, or ACA? And this is something you need to be aware of. So certainly, you need to fix Medicare. Why do we need to fix Medicare? Is because we can't afford it. Right? The baby boomers are all approaching retirement age, and healthcare is getting more expensive, so it's simply not sustainable. We have a huge number of uninsured patients, and in Los Angeles County, we have more uninsured patients than there are people in most states in this country. We certainly need to control costs. We know the costs are out of control, and this is really probably the most important thing in this whole ACA is improve quality and efficiency. And this is a theme I'm going to talk about throughout this presentation, is a focus on quality. Now, obviously, if we go to nationalized health care, if this law is not overturned by the Supreme Court, the concept is everyone will have some type of health insurance, so that will improve. But this is something that's really been sorely lacking in American health care is prevention and wellness. And if you look at the literature, you know that, for example, the number of surgeries for low back pain varies widely amongst different parts of the country. So in some cities, it's very, very high. Other cities, it's very low. But the outcomes are basically the same. So if you really want to drill down on it, if you have severe back pain without leg or arm, if you have without leg pain and no motor weakness, that back surgery is probably not a good idea or is not going to help you. But people go in for these procedures all the time, and why? Because currently, what's the reimbursement model for healthcare in this country? You get paid based on quantity, not quality. So the more procedures we do, the more we get paid. And that's what's driven a very, very inefficient healthcare system. So reimbursement under ACOs, or accountable care organizations. You remember HMOs, like the Kaisers of the world, health maintenance organizations, are now being called accountable care organizations, or ACOs. So this is a new acronym for this decade. So ACOs, the concept is reimbursement based on quality of care. And the focus is avoid unnecessary testing and procedure. And how do we drive cost-efficient medicine? Well, if we have a paradigm shift in healthcare, so for a certain diagnosis, for example, say low back pain, if there's a simple flat fee that all the providers are paid for that diagnosis, certainly you don't want to do expensive procedures and surgical intervention because you're not going to make money on it. So there becomes an incentive to keep those patients out of the hospital and certainly keep them out of the OR. So it's a focus on injury prevention and wellness rather than treating injury and treating sickness. So it's a paradigm shift, become more cost-effective and hopefully improve health care in this country. Now, how does this impact EMS? Well, it's pretty obvious how it impacts EMS. Now the ACO, the ACA, the Affordable Care Act, is 1,900 pages long. EMS is only mentioned 4 times in that entire document, 4 times. However, we definitely will be impacted because the ACA pays for outcomes, not fee for service. So the traditional EMS model is we send any number of providers. You may or may not have tier dispatch. You may have most places now have fire department as first responders. Fire departments may or may not provide transport, but where's the reimbursement right now in EMS? It's in transport. So if you have paramedics on your fire engines and you get to that incident in 4 minutes, and you provide high-level, high-skilled, high-quality ALS care to that patient within 4 minutes of the 911 call, do you get paid? Who gets paid? Whoever transports the patient to the hospital. Okay, so that model is unsustainable. So therefore, is there an incentive right now for EMS providers to keep people out of the ERs? No, it's quite the opposite. So if your paramedics are highly skilled and they have good medical oversight and online medical control, and you have some type of treat and release policies, is that going to help your system? No, because all of a sudden now you can't sustain it because every time you don't transport a patient, you're losing potential revenue. So that's why we need a paradigm shift, and a lot of parts of the Healthcare Reform or Affordable Care Act actually do make sense. And if you do the wrong thing, no one's going to pay you. So if you notice now when patients come into the emergency department and they get admitted, particularly health patients from nursing homes, why are nurses vigilant now about taking pictures of pre-existing decubiti, bed sores? Because if a patient develops a bed sore in the hospital has to pay for it. Medicare will not reimburse the hospital. Medicare will not reimburse the hospital for ventilator-associated pneumonia. Medicare won't reimburse the hospital for central line sepsis. So this cost-effective medicine is driving improvement in quality. So if there are iatrogenic complications, meaning complications that you did, I did, nursing, anyone in the healthcare chain is responsible for, we will not get paid for it. And that's what's driving the change. So obviously, what's driving all these changes is not just politics because this is an election year. But you all know that healthcare now is the largest part of personal consumption in the US economy. And what really should frighten everybody here, what is the #1 cause of bankruptcies in the United States? It's due to medical bills. And that should cause everyone, give everyone here a great pause. Think about it. #1 cause of bankruptcy in this country is from medical expenses. And who gets squeezed the most? It's those unfortunate enough people who have jobs, but they lost their health insurance, or people who lost their jobs due to the recession, and they had a good paying job that provided good medical coverage through their employer. Now they had to take a lower paying job without medical benefits, and they come down with a bad diagnosis like a malignancy, or they're in some type of accident, or they need a very expensive care and rehab, and they get hit with a $100,000 hospital bill, and they lose their house. So this is a real problem, and this is clearly unsustainable. It's projected that almost 50% of federal spending by the year 2050 will be due to healthcare based on the current rates. And right now, 17% of the GDP goes to healthcare. Clearly not sustainable. And again, 16% of the population uninsured. And what's most concerning, now if you say, well, you know what, you get what you pay for. So if I want to buy a really expensive car because it's safe and I want to be comfortable, you get what you pay for. You want to buy a jalopy, not so safe, and it may break down. That's capitalism. The problem is almost a third of health costs, $700 billion, are due to interventions and treatment modalities that are thought to be of little or no value. So it's money for nothing. That's the problem. This graph really sums it up. Look at this look how steep that curve is. This is the US healthcare spending as a percent of the gross domestic product from 1960 to 2007. Clearly, at a certain point, that line will fall off the cliff. So clearly, this is unsustainable. And how do we stack up compared to other industrialized countries around the world? Well, the US here is on top, and this line is actually a number of dollars adjusted for, per capita. So right now, it's about $10,000 per American spent on healthcare right now, and you see how far we are compared to all the other industrialized countries around the world. And by every quantifiable measure of healthcare outcome, healthcare quality, US is nowhere near #1. So we're very expensive, but we're not getting the bang for the buck, and that's the problem. So where do we go from here? Well, we have to look at data and research. What is the evidence for what we do in healthcare? And that includes EMS. What is the evidence for what you do out there every day? So health information technology is really just starting to grow and starting to gain traction. And again, there's going to be an emphasis on primary care and prevention. And what's the problem there? A lot of med students go into primary care. Why not? There's no money in it. So you go to college for 4 years, you go to med school for 4 years, you do 3 years of family practice training to go into preventive or primary care, and you come out with $200,000 in loans, making $100,000 a year. Do the same thing, go into a surgical subspecialty, and you make 3 or 4 times that. So it's been very, very difficult over the last 10 to 20 years to attract young physicians to go into primary care, so there's a huge shortage of primary care physicians in this country, but it's got to start there. Primary care and prevention. You know, the old proverb, an ounce of prevention is worth a pound of cure, is really, really true, and that's really the focus of the changes now. So what does the future hold? Well, most fire departments lack the sophistication that some of the other aspects of the healthcare have to verify what they're doing and quantify what they're doing. Quality controls that we've seen develop in hospitals, certainly over the last 10 years, for the most part are non-existent in the healthcare, in pre-hospital care, and that includes fire-based EMS. Now, people here who work in hospitals, nurses and physicians, if I mention JACO or Joint Commission, most people kind of pull back in disgust. But if you think about it, Joint Commission has driven a lot of positive changes that actually improve the health of our patients. Because the things that's the bane of our existence, how do you know when Joint Commission's making a hospital visit for a survey? They hide the coffee maker, right? No physician, nurses' lunches in the blood bank refrigerator. All the things that make life comfortable in the ER. Pull our food away, clean up, don't reuse the lidocaine bottles, all that stuff. But where does it make a difference? The incidence of complications, iatrogenic complications in hospitals has gone way down. So we've all heard the horrific stories on the news where surgeons operate on the wrong limb. They remove the wrong organ. So surgical pauses and timeouts before every procedure. Going through a double and triple checklist to verify you have the right patient before you transfuse blood. Going through a huge change in how we place central lines in hospitals because of the incidence of central line infections and ventilator-associated pneumonia, which is associated with a huge, huge mortality rate. So there's really been a major paradigm shift in the in-hospital care setting to decrease preventable errors and morbidity and mortality, and this is now falling on EMS as well. So your department has to have a comprehensive quality management system in place. And one of the things that probably is my pet peeve, working in EMS as many years as I have, and this is not just fire-based EMS. I started as a paramedic in New York. At that time, we were called a third provider. We were separate from the fire department. But everyone always brags that we're the best EMS system in the country. We're the best fire department in the country. And when I hear people say that, I say, well, how do you know? Well, I just know. Well, you know, the old adage is true. All fires go out eventually, and all bleeding stops eventually. So they say, well, we put the fire out. Well, did you lose one room or did you lose the whole house? Well, we went into this major trauma of patient, auto versus pedestrian, and we did everything we could. And we started 2 IVs, and we C-spined the patient, and we intubated them, and we did all this stuff, and we got them to the trauma center. How do you do? Well, the patient died. But it wasn't anything we could have done. It was kind of fait accompli. Well, how do you know? You don't know unless you try to measure it. And I think that's the difference between striving for excellence versus mediocrity. So who are the most successful coaches? You know, the John Woodens of the world, basically, if your football team or your basketball team wins the game, that's not good enough. If you win 35-3, the good coach will say, you know what, great win, but we should have shut them out. How'd they score 3 points off us? So do you have a comprehensive quality management system in place in your department to say, yeah, we're pretty good, but how do we get even better? And not to assume that if the patient doesn't do well, there was nothing we could have done differently, but really critically analyze every aspect of your system, starting with dispatch, or the call processing till it gets to your dispatch center, to every aspect of your care, because what you do out there clearly impacts how the patient does in the long run. So the hospitals have really focused on something called root cause analysis, which makes sense. If there's a problem, if there's a sentinel event, If there's an unexpected death, you can't just look at the surface. Well, I have weeds in my garden. What's the root cause of the weeds? Is go below and look at the roots. So we do this really well at my shop, and we're certainly, I think, one of the largest trauma centers, one of the busiest trauma centers in the country at LA County USC Medical Center. And what we do is, for example, every single trauma patient who comes to our facility and doesn't walk out. So all trauma deaths are reviewed, and it's not just by the trauma surgeons. And what's interesting, so we have this combined multidisciplinary death committee. Sounds kind of morbid. We meet over lunch too, believe it or not. But who do you think chairs this committee? The chair of this committee is Dr. Noguchi, who's one of the most famous former medical examiners. So you have someone who's been a coroner for 30 or 40 years who chairs the committee. And on the committee is not just trauma surgeons, there's emergency physicians, there's critical care people, there's nursing. So all the stakeholders are there. And for every trauma patient that dies, is an exhaustive analysis to determine, was that death preventable? Was it non-preventable? Or was it potentially preventable? And if it's potentially preventable or preventable, after a root cause analysis, you go back and you say, how can we educate everybody, and not just everybody involved who may have screwed up on that case, but how do we teach everybody involved so those same errors are not made on the next case? And that's the value of closing that QI loop and really doing a good root cause analysis. And it's not just focusing on the individual. The QA aspect is, Joe paramedic made a mistake. The QI aspect is systems analysis to say, well, if Joe Smith paramedic made that mistake, could the next ambulance, could the other paramedics or the 500 paramedics make the same mistake tomorrow? Well, perhaps. Have we done adequate training on this? Do we need retraining? We need to put the word out there. Because typically, if someone makes a mistake, barring gross negligence, usually that mistake may happen again and again unless we look at things from a macro perspective. So evidence-based medicine, or EBM, which is the buzzword in the last 10 years in the house of healthcare, how does that relate to EMS? So where is the evidence for what we do, and are we cost-effective? So let me go to the second bullet point. Do you think we're cost-effective? What do y'all think? Honestly. If you had to design an EMS, so if you wrote the checks and you had to design an EMS system from the ground up, you think you could do it more efficiently? Or if you had to compete with the private sector, do you think you'd be more efficient? So in the free market economy, what really drives change and innovation? Competition. Well, for the most part, every municipal EMS provider is a monopoly. So look at the US Postal Service. What happened when FedEx was created and UPS was created? They try to become more efficient, but where's the US Postal Service right now? Hanging on by a thread, losing about $2 billion a year. Right? So competition drives innovation, drives change. So this kind of sums it up. I'm stumped, we'll have to wait for the autopsy. This is a quote from Dr. Mike Callahan, who's a chairman of emergency medicine, very well-known emergency physician, runs the UCSF program. He wrote an article that came out in 1997 in the Annals of Emergency Medicine that you can imagine really stirred up a hornet's nest in EMS. He said there's virtually no aspect of EMS that can meet the current requirements of the FDA for approval as a safe and effective new therapy, because there was little to no evidence for almost everything we do in EMS. And that really gave most of us great pause and great concern. And we said, is he right? Is he right? And when this came out, I started to look at the literature and things that we've accepted as tradition and dogma. And you ask people, why do we do certain things? Why do we give IVs for trauma patients? Why do we immobilize trauma patients? Why do we give oxygen to everybody? The answer is what? We've always done it that way. Must be a good thing. To actually look at the literature and see. So it's time for EMS to look different. So what role does EMS play currently, and what role can EMS play in the future on injury prevention, community-based care, and reducing hospital readmissions? So some systems, for example, Alameda County up in Northern California now, they got this big federal grant where paramedics are doing some community outreach. They do healthcare screenings. Some systems have advanced care paramedics or advanced practice paramedics or APPs, where paramedics with additional training go to the homes of the so-called frequent flyers. And these aren't 911 abusers. These are people who are in and out of the healthcare system with CHF and brittle diabetes and uncontrolled hypertension and chronic wounds and alcoholism and substance abuse, and make periodic home visits to keep them out of the hospital. And now that hospitals are becoming ACOs or accountable care organizations, the hospitals will have an incentive to pay EMS agencies and fire departments to say, hey, if you're paramedics and go to Mrs. Smith's house to check her blood pressure, make sure her ankles aren't swollen with edema, control her blood pressure, do some wound changes and keep her out of our ER and ICU, we'll pay you, because if she comes to our hospital, has to be admitted, we're going to lose money on her under the new healthcare scheme. So everything's changing. Right now, we're only paid to transport. We should be paid not to transport. And change, something causes fear amongst most people, but change is a good thing, as long as it's based on good evidence and best practice. This is one of my favorite quotes. Albert Einstein said, how do you define insanity? Insanity is defined as doing the same thing over and over again and expecting a different result. So I work at a very large teaching hospital. I have 72 residents in my program. When I see a resident go and intubate somebody and they can't get it the first time, and they bag them, I say, it's taking too long, let's pull out, bag for a few seconds, pulse ox comes up again, okay, let me go again. And they do the exact same approach with the exact same tool and the exact size, same blade. I said, you didn't get it the first time, you do it the same way this time, what makes you think it's be any different? It goes back to this quote. And that's kind of what we've been doing at EMS. So tradition, we all know the definition of tradition. And at the risk of insulting a lot of people here, you know the next quote, right? Everybody's heard this quote. And I think the leaders in the fire service are the first people to tell you, yeah, the fire service has been 100 years of tradition unimpeded by progress. And the fire departments, I think the fire service in this country are in a very unique position because fire service, firefighters in general, are still amongst the most respected professions in the entire country. This has been shown time and time again. So firefighters are very highly respected and are pillars of the community. But fire departments now also have to change because the way we operate is unsustainable, and our operations are based on past practice and ancient history. So the city of Los Angeles, for example, we have on average, we have about 35 fatalities per year in a city of 4 to 5 million people due to structure fires. We have, barring every 5 years or so, we have conflagrations from brush fires because we live in brush fire territory in Southern California, not to mention earthquakes and everything else. But unless we have the massive conflagration brush fire, which, knock on wood, we haven't had in the last few years, we actually have a higher monetary loss in the city of Los Angeles due to property from water damage, from sprinklers from fires, than smoke and fire. Now, why is that? Because the fire service has been so effective with changing the laws and changing the fire codes, so every new house and every new building in California has to be sprinklered. Smoke detectors are mandatory. There's a new law in California now, all new homes have to have carbon monoxide detectors. So they've been very effective, and a former deputy chief in my department, who should rest in peace, who was one of the most well-respected fireground commanders in the history of the fire service, said, within 10 years, our fire prevention is going to put us out of business. And he's almost been right about that. And it's kind of funny if you think about it, do patients spontaneously combust? And here's a picture of a traffic accident in my city. And paramedics are putting a traction splint on this young woman with a femur fracture. And what do you notice in the picture here? They got the fire hose ready in case the scalp spontaneously combusts. I don't know, it could happen. See it every time. That's just the drill. Even if you have to get the jaws out and pop a door, someone's got to be there with a protection line. And now it's aimed right at her femur in case maybe the two broken ends of the bone, I don't know, friction or something. This is an article that came out, many years ago. This came out in 2001, so over 10 years ago, and everybody knows this article. This wasn't exactly the best scientific piece ever written, but the fact that these guys had the cojones to print this, right? This is really simple. They look at Orlando Regional Medical Center out by Disney World in Florida, and they looked at all patients coming into their ER that were intubated in the field, and then what they find that 25% of the tubes were misplaced when they came in. 1 out of 4. Wow. Would you go to get your shoulder or knee fixed or outpatient procedure at a hospital where the anesthesiologist misplaced 1 out of 4 tubes with a mortality rate over 50%? And certainly you could argue every one of those is potentially preventable. And of course that drove change. How to drive change? Capnography, digital waveform capnography, full-time medical direction. But this is considered a landmark paper because it really shook the tree. And there was some low-hanging fruit there to say we could fix this. This wasn't the paramedics' fault. Their training and equipment and lack of medical oversight was the problem. But this really highlighted some of the problems that existed in EMS, and this obviously got a lot of play. So the issues that are affecting the healthcare system has really gotten front page. This was an article in the LA Times last week, front page last Monday, LA County's 911 system burdened by non-emergency calls. Now, there's nobody in this room who's not aware of that, no matter where you work, but most of your calls aren't time-critical emergencies. And what's interesting is they talk about a particular call where a gentleman called from a county health clinic in LA. He called up and says, I have gout, my joints hurt, I need a med refill, I need to get to an ER. They won't see me at the clinic. And I run City Fire. County Fire is a sister agency. And who do you think they sent to this call? Emergency lights and sirens. Fire engine, 2 paramedics in a squad, and a private ambulance. Now, of course, what this article didn't talk about is, why'd you send so many people to this call? So they talk about how we send all these people rushing to these calls, and the people who don't have a true medical emergency are just burying the system and burning out our providers. And what can we do about it? And there's no easy answers. And are we really changing as quickly as possible? So the Institute of Medicine came out with a report on EMS 6 years ago. It says EMS at the crossroads. And this was really prophetic and ahead of its time, because one of the key recommendations in this report was the concept of accountability. And they said Health and Human Services should develop evidence-based indicators of emergency care system performance. Evidence-based, meaning we need good data and research to say what we are doing for our patients saves lives. Saves lives. When I was a paramedic, we prided ourselves, and this is, worked at a time when crack cocaine first hit the streets in New York in the mid to late 80s. So the number of shootings and violent crime was absolutely insane. And we prided ourselves at every shooting we went to, how quickly we put in those 2 14-gauge angios and pumped up the mask pants. And if you brought a shooting victim into the ER without mask pants inflated and 2 14-gauge angios and 2 liters of ringers hanging, you weren't worth your salt as a medic. Yet mask pants were based on, you would think, robust literature, right? Mask pants were a mandatory piece of equipment on every ambulance in this country a short time ago. Mandatory. And the evidence for mask pants was based on a case series of about 25 patients from Miami. That was the so-called science behind it. So we all know value. What's the value added? Or what we are doing is it value added. When I first put 12 leads into our system 7 or 8 years ago, how did I sell my paramedics on it? Now, my paramedics will, like all y'all, say, you want us to do more interventions in the field, more work, show me that's going to help my patients, then I'm willing to do it. If it's just busy work, I don't want to do it. Well, I said, you want to identify these heart attacks, and trust me, in a few years, we'll divert these patients with acute MIs, they weren't called STEMIs at the time, to places where they go right for angioplasty. And of course, we now, nationwide, that's having a huge impact. So we know EMS really started with Dr. Frank Pantridge, who was a cardiologist. He saw these young men in their early 40s coming into his hospital in Belfast, Ireland, dead from MIs, and he knew there were VFib arrests in the field, and it was too late. Let's bring a defibrillator to the streets and save these people. And we know since then, things have changed. Now, I actually still have my paramedic treatment protocols from New York City from 1987 when I was a paramedic. And it's interesting, and I incorporate into some lectures I give to think about how things have changed. So I know you can't see this in the back. This was our protocol for PEA, or we called it idioventricular rhythm at the time. We now call PEA. At the time, it was called EMD, for those of you who remember that. And look at the drugs involved there. Isoprel, mask pants, and Decadron. Probably what's the worst drug you can give to a pulseless victim of cardiac arrest? It's isoproterenol, pure beta agonist. Right? So a lot of things we did, not based on science, but it sounded good. We know what works for cardiac arrest now, right? Chest compressions, cooling, defibrillation, we know what works. Trauma care, does ALS work for trauma care? Literature says no. IV fluids don't work for a number of reasons. And we've seen the literature over and over and over on that. And we did a study in LA we called our Homeboy Ambulance Study. Right? I work in the barrio in East LA. I know most of the gang members on a first name basis, and I've been there so long I delivered half of them when I did labor and delivery as an intern 23 years ago. And we had a lot of patients, particularly in the early 90s, who got shot up, and their buddies drove them up to the ER. So we hear the peeling rubber coming up to the ER, car stops, the driver bolts out, and you see someone bleeding in the front seat, and the car is all riddled with bullets like the Bonnie and Clyde car. And we got those, we call them homeboy drop-offs. And we did a study looking at what was the outcome of the homeboy drop-offs versus the shooting patients who came in by EMS. And who do you think did better in every category? The homeboy drop-offs. Now, was it because my paramedics did something wrong? No, but we drill down and look at the root cause analysis. At that time, their average on-scene time for penetrating trauma patients was 23 minutes. 23 minutes, and that was the early 90s. So how do we fix that? We went out and retrained them, because what was the on-scene time for homeboy ambulance drop-offs? 0. Matter of fact, they have to even load them because these usually drive-by shootings car to car. So how do we fix that? Well, now paramedics know, and they pride themselves. They bring me a shooting victim. They say, hey, doc, we're off scene in less than 5 minutes. Right? But unless you looked at that and looked at the data and compared it to something, you would never know. And say, don't worry about the IVs. You can try IV en route, probably doesn't help, but the main thing is get them here as quickly as possible. So you have to look and see what you're doing. And the status quo, why does everybody who calls 911 need an IV, a backboard, and high-flow O2? Matter of fact, the things you'll be hearing about in the next few years, high-flow oxygen probably kills a lot of patients. It's certainly shown to be true in post-arrest patients. It's probably true in stroke patients. So things change. How about non-tiered dispatch and code 3 driving? So if you work in a system that doesn't have tiered dispatch, meaning you send everybody lights and sirens and send everybody lights and sirens to everything, is there risk involved there? Of course. What are the risks? Crashing, right? So we got to question the status quo. Now we know there are things that we think as gospel in EMS, right? Innovation. Now when I was a paramedic in New York, we were just taught in the late, like 87, how to intubate kids, pediatric intubation. And we were trained on kittens, and now the vivisectionist would never let you do that, so you had to use mannequins now. It was a cool thing. You think, my God, I want to save a critically injured, sick kid. But when they actually did the study in LA and looked at pediatric intubation, the kids who got intubated versus the kids who got bag valve mask, outcomes were no different. Matter of fact, the kids who got bagged trended towards better than the kids who got intubated. And there are lots of reasons to that, but what was the main reason? The study in LA showed no benefit, and other studies that were not as robust, and other cities found the same thing. On average, how often does a paramedic in the United States intubate a kid? On average, once every 20 years. So how could you possibly maintain proficiency on a skill you do once a career? Rapid sequence intubation, really hot topic in EMS. Risk benefit, very risky. Air ambulances. Literature is very, very controversial on that. Does it save lives? Sometimes yes. A lot of patients, though, probably don't need it. And if a lot of the hospital-based helicopters, there's a huge profit motive there. And we know, sadly, a lot of those, the incidence of crashes of air ambulances is unacceptably high. Matter of fact, this got attention in the lay press. There was a hearing at the congressional level on this. And I could tell you, if commercial airline industry in this country had the crash rate of medical air ambulances, every plane in this country would have been grounded, every one of them. How about ALS versus BLS? Used to be pretty easy. Here's a set of skills that are BLS, here's a set of skills that are ALS. But I bet if we had time and we had a chance to poll everybody in this audience and say, you think this is ALS or BLS? Well, defibrillation, I think most people now would say is BLS, or I would argue now is maybe a lay rescuer skill because we have public access to defibrillators. 15 years ago, we would say it was an ALS skill. 25 years ago, you'd say it was a physician-only skill, right? Auto-injectors. Every single patient I see in my emergency department, wherever I work, that comes in with an anaphylactic reaction, I send home with a prescription for an EpiPen, right? So you could argue that's a lay skill, let alone an ALS skill. Sublingual nitro, some states and jurisdictions have an advanced scope of practice for paramedics to give sublingual nitro. Some dispatch centers, my own included, where the emergency medical dispatcher will instruct the caller with chest pain to go ahead and self-administer an aspirin. So is it ALS, BLS, or a lay skill? Nebulizers, some EMTs are allowed to give nebulizers in the field. Narcan can be given IM, IO, sublingual. You could throw it at a patient, it'll probably work. ALS, BLS, and you probably have heard, the controversy with drug exchange, needle exchange programs in certain cities, particularly cities where it's highly impacted with heroin addicts. Well, now some cities you might have heard about are actually giving out auto-injectors of Narcan, which makes sense. Makes sense. Clean needle and a clean auto-injector of Narcan. So if you overdose and you have a buddy with you, he can reverse you before you die, or worse yet, have anoxic encephalopathy and have brain damage. And sometimes the patient actually helps you make the diagnosis and makes it easy. So it's easy in my ER. The patient comes in and says, here's what's wrong with me. Like, what's wrong with you, sir? He blinked. Oh, I get it. Okay. How about how many paramedics are in your system? So some systems are still all ALS. Others are a mix of ALS, BLS, or certified first responders. And is this a good use of resource? Is this cost effective? And I would argue, venture to bet, almost every EMS system in this country and probably around the world, overwhelming majority of your calls do not require ALS. Now, you could bill anyone for ALS because the current CMS guidelines to bill for ALS is pretty easy. If I put a pulse ox probe on your finger, I could bill for ALS. So if you stub your toe and I get a pulse ox reading and document it, I could bill for ALS. But in terms of patients that actually need ALS, it's a small percentage. And of course, how do you define that? Is it IVO2 monitor and pulse ox? And if you look at the number of patients who actually get intravenous medication, the number is even smaller. So you could argue, does it make sense to have an all ALS system if the overwhelming majority of your calls are BLS? Because you have dilution of skills, you have cost of training, and again, just like the peds intubation, how do you maintain proficiency on very high-risk, low-frequency interventions if you have so many paramedics? I have about 1,000 paramedics in my system in the city of LA, and we have a little bit under 1,000 intubations per year. Some medics get a lot of them because they work in high-acuity neighborhoods. Others get very few. So it poses some significant challenges. Dispatch for dummies, very simple. This summarizes dispatch. They call, we send, you go. That's it. But do you have tiered dispatch? Now, a lot of my providers would argue dispatch center never gets it right. Well, sometimes they do. Knife still stuck in his stomach, and this was the patient. So sometimes they do get it right. They were right on that one. Code 3 driving, right? The literature is unambiguous on the fact, we said most calls are not time critical. Hopefully you can distill that when you have trained emergency medical dispatchers, and we know there is a significant risk with Code 3 driving. And then once you've evaluated the patient, how many systems, and my own system, people do it all the time as well, decide to transport Code 3 to the hospital because, oh, I want to get back in service, I want to get back to quarters, there's a lot of traffic, and I hear them, call up, yeah, we'll come in with a stable patient, vital signs stable, con home patient, more altered than usual. And I hear the sirens. Is that risky? Absolutely. And sadly, this is all too common. Now, we're fortunate in that we respond to about 350,000 EMS calls annually in the city of LA, about 850 a day. We transport about 600 patients a day. And because of the skill of our folks, these incidents are very rare. But when they happen, they're not only tragic for the victims and their families, but the engineer, firefighter driving this rig, has to live with that. And this is a case where, and these, you know how these happen, right? The light, the engine's going around an intersection, and everyone stops, and there's an 80-year-old woman driving this car, and she's waiting to make a left turn. Fire engine's coming around, cut through the intersection, reported smoke, and she sees oncoming traffic stop. So, oh, how nice, they're letting me make a left turn. She turns left and gets nailed. This was a Holocaust survivor, killed instantly on impact. Can you imagine, to this day, the guilt of the engineer driving that rig? Beyond horrible. And of course, almost all these calls turn out to be nothing calls on top of it. There's another one. This turned out to be a dead body. And when one of our ladder trucks hits a car, almost all of those are fatal, just due to the weight differential. Amazing the paramedics survived this. This ambulance literally exploded on impact. I don't know how they got out virtually unscathed. In this incident, people weren't so lucky. And of course, what was the response? What was the dispatch on this? Reported smoke, and what did it turn out to be? Rubbish in an alley. 2 dead, 3 critical. So things could change. Air ambulance, I talked about, this is one of our newer helicopters, and we lost one in 1997, flying a stable patient to our children's hospital. The child died, one of the pilots died, we lost 2 paramedics. Horrible. And I've been to a lot of autopsies, but seeing people wearing uniform in my department on those slabs, I'll never forget that as long as I live. And then I was on a Man with a Mission saying, wait a minute, why are we flying patients who are stable? Because that's insult to injury. We lost these people for nothing. So we have to change. We have to do better. So what does this all mean? Evidence-based medicine. Now, should everything we do in EMS be subjected to rigorous science? Is there any room for common sense? Where do we go from here? So this is one of my favorite studies. This is one of my favorite studies actually published in peer-reviewed literature in the British Medical Journal. Parachute used to prevent death and major trauma related to gravitational challenge, a systematic review of randomized controlled trials, published in 2003. Objectives: to determine whether parachutes are effective in preventing major trauma related to gravitational challenge. Design: systematic review of randomized controlled trials. Main outcome measure: death or major trauma defined as injury severity score over 15. Anybody want to volunteer for that study in the no parachute group? The results: we were unable to identify any randomized controlled trials of parachute intervention. Conclusions: as with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation by using randomized controlled trials. Wow. This was profound. What's the point of this study? They said that basically advocates of evidence-based medicine say everything has to be subjected to rigorous study with prospective randomized controlled trials. I don't think anyone wants to volunteer for the no parachute placebo group, right? So what they concluded was individuals who insist on all interventions being subjected and validated to randomized controlled trials need to come down to earth with a bump. Because we know certain things we know works. We know chest compressions work. Given a shot of adrenaline for anaphylaxis, we know works. Some of this we've studied, some of this we know is intuitively obvious. Basic life support, the Heimlich maneuver we know works. I don't think you want to volunteer for a controlled trial. Okay, next person's choking on odd days, you don't do anything. On even days, you do the Heimlich, right? So certain things we know is obvious. I don't need a trial to tell me that. Electricity works for shockable rhythms. And how do we measure ourselves? What's the easiest way to measure our effectiveness? Response times, right? The politicians love response times. And how do we measure response times? We measure it, we look at all calls, including non-emergency responses. So if someone's back pain for 10 years, we send a BLS ambulance, non-emergency. Why do I care how long it took to get there? It should be how quickly we get there for time-critical calls. And of course, we've been slammed by the media in the last couple of months. Our response times are all over the map. They've been made up. They're projections. The union's all over it. LA Times all over it. It's a mess. And who pays for all this? Financial support. It's really a lack of financial support. LA's going broke like most cities in America. It sounds like from talking to colleagues here that you guys have been more fortunate than most. Our budget crisis in LA next fiscal year, $250 million deficit, getting worse. No firefighters have been laid off, but we've lost resources. So we shut down engine companies. These are posters that our union put up on fire stations that have been impacted, saying you're risk to die, your family members jeopardized. Demand from the mayor and city council reinstate, get your engine companies back. And this is a big, big political deal, and there are newspapers running with it, and the LA Times running with it, and the union's not saying, let's get cost-effective and put more ambulances out there. All those fire trucks we closed, we need to put them all back. That's like saying we need the same number of tanks in the Army now as we did in 1945. Okay? It doesn't work that way. You know, we actually train more people to fly drones with a joystick sitting in a bunker in Nevada today than we train fighter pilots, right? So times change. Ambulance fees have gone up to try to recoup the difference. It costs about $1,500 for paramedics to take you from point A to point B in LA. Some people pay it, some don't, some pay in the middle. That's a lot of money. Not sustainable. So it comes down to supply and demand. There's a graph of LAFD EMS incidents on here, slowly going up from the last 10 years. Transports, as you might expect, paralleling that. Non-EMS incidents, structure fires, flattened out. We go to about 10 structure fires a day and almost 1,000 EMS runs a day. And it's slowly trending up. So call load, demand's going up, and what do you think's happened to our budget? Taking a big hit after the recession hit. And now the privates want a piece of the action. Now, I don't blame AMR, because if I worked for AMR, I would say, hey, LA City is drowning in red ink. They're billing almost $1,500 for a ride to the hospital by paramedics, and they're billing $850 for an EMT ride to the hospital, and they're paying the firefighters about $40 an hour, and we pay our kids $15 an hour. That's a pretty good business model. So they want a piece of the action. It's happening in LA, it's happening in Dallas. So now the fire service, we thought we were untouchable, we're being forced to compete. Never happened before. So I would argue that EMS is a practice of medicine. What does the future hold? Well, we know, Adam Smith said back in the late 1700s, we know the hand that goes like this, the economy clearly is cyclical. Hopefully we're coming back out of it. Some cities like LA slower than others, but the economy is cyclical. Fire suppression calls keep declining. Why? Because of effective fire prevention by the fire departments. That's a good thing. Fire deaths, fatalities, property loss has gone down. EMS calls keep rising. And if you think nationalized health care is going to decrease EMS calls, if you look what happened under Romney Care in Massachusetts, the ERs got busier. So even if the nationalized health care goes through and withstands a challenge at the Supreme Court, don't think our workload is going to go down anytime soon. Nationalized health care or some health care reform in the U.S. clearly is coming. The current model is unsustainable. I don't think the healthcare industry will look anything like it does today in 5 years. The change is already there. All the doctors at every specialty now are shifting to become hospital-based employees because they can't make it on the outside. 60% of cardiologists now are hospital-based employees because they can't make the money, they can't fight, they're tired of fighting with the insurance companies, they can't run a business in an office. Things are starting to change. Healthcare reform is coming. You guys are all part of healthcare, and you will be impacted. EMS is clearly not immune. And the old adage of innovate or become extinct, which is true in business, is finally coming to fruition in pre-hospital healthcare. But I think the best way to sum this up is, despite the financial crises, increasing demand, a rapidly changing healthcare system, never-ending politics, which we know too well, I think EMS really comes down to these three things. We manage often, we cure occasionally, but we care always. It's been my honor and privilege to speak to you today. Thank you very much.